Hi, Alison. Thank you so much for joining me on the Business of Healthcare podcast and specifically on our series called How It Got Commissioned. Would you be able to share a little bit about who you are and what you do?
Yeah, so I'm Alison Gardiner. I'm a co-founder and chief exec of Sleepstation, Born Digital Health, which probably the product that we're best known for is Sleepstation, which is a online insomnia service. My background is in behavioral psychology, so I specialize in the development of persuasive technologies, and Sleepstation is basically, I could make it the short way, is to say it's a digital sleep doctor. So what we did is we kind of digitized care that was happening in the hospital and brought it to people's homes so they can access that care and support anywhere they are across the world.
So, if we just focus on Sleepstation, what was the problem you were trying to solve?
So when we started, so Sleepstation kind of started as a project really in 2011. So I was doing other things in kind of behavioural psychology, and a doctor at Newcastle Hospital came to us to see if we could build something that might help reduce waiting lists at the local hospital. So we're looking to speed up some of those processes by digitising some of the data inputs, and also to give more time for the real proper care that you need with the patient face to face by dealing with some of the kind of educational pieces digitally. So it started off as a project, and it's kind of grown legs from there over the last 13 years.
How many clients do you or have you had?
Oh, hundreds of thousands. So we're the largest digital sleep clinic in the NHS. So we previously had a national contract before specialised commission moved out, before insomnia moved out of specialised commissioning. So our service was commissioned by NHS England from 2016 to 2021. And under that contract, we saw thousands of patients across the whole of England every month. So really, really large service. We see more patients in a month still than the largest sleep services in the NHSC in a year. So really significant. And then following that, so we'd launched a service in the NHS initially. Then we'd secured this national contract where unfortunately we weren't allowed to talk about it, but we were available nationally for a long time. And then COVID hit. So during COVID, obviously that spiked even further. So we significantly larger numbers of patients and looking at kind of different diverse groups. And then people started thinking about digital services a bit differently as well. So it wasn't something that people considered niche anymore. It became like a real proper part of care.
Can you share an example of how you got commissioned when you didn't initially just respond to a tender?
A part of the care that they're finding it difficult to manage, and we've kind of been able to combine our services with them to support them. So one example is where you're based in West Kent. Our service there was a partnership with the IAP team there, with the talking therapies team, to look at could we support more of the patients who were presenting with insomnia or with depression or anxiety, but actually really significant sleep problems. And if we could resolve the sleep problems, we'd probably bring them off the waiting list for those services. So that wasn't a direct commissioning, that was just working in partnership with the IAP team to say, if we see these patients early and actually, they've got more prevalent sleep problems, and that's probably what's kind of driving this cycle of depression, do they really need to see you afterwards? So part of that kind of step care approach, and that was really effective. And actually, some of our outcomes for the impact on comorbid anxiety and depression are actually better than some of those services. Well, better than what the targets are for IAP services today, because sleep and mental health problems are so strongly linked.
And how long were you commissioned to do that for?
That was a 3-year contract.
Interesting. So one of the things that I really wanted to speak to was people that had got a contract commissioned for longer than a year. So your 3-year contract, was it just like, oh, we're going to do it for 3 years? Or was it very intentional about the length of time of the contract? How did they have the money? Could you talk a little bit more about that?
A lot of those contracts are typically multi-year contracts. And we were working with a provider who had a contract that ran up to a certain period. So we were committed to supporting them until their contract ended. So yeah, that's more of a kind of partnership collaboration agreement. And I think whenever you're looking at what the problems really are, like if you think about the system more broadly rather than just thinking about how do I get my service commissioned, those kind of opportunities open up, don't they? Because you can look and say, oh, well, these guys are doing this thing and they're targeted with delivering X, and we can support them with that element of it. And then it really makes sense to partner together. But you need to kind of have that collaborative thinking. And I think your business has to be geared up a certain way to work in those kind of contracts, a lot of businesses are quite focused on just delivering what they do. And I think that's when it becomes quite a lot harder to get specific contracts, because often the system maybe doesn't see the problem in the way that you do. And you might think, oh, there's this problem that we can solve really well, but there's all these other problems. And there's the potential impact that if we solve that thing, does it then cause a bigger problem down the line? So you do really have to be thinking about the system as a whole rather than just what you're seeking to gain for your particular organisation.
With that particular contract, did you have any issues with scale?
So I don't think you should ever take on a contract if you don't know that you'd be able to deliver against the targets or what you're being asked to deliver against. And in the NHS, obviously, there's waiting list targets and recovery targets and things like that I think you need to be really mindful of being able to deliver against before you would agree to take anything on. So we certainly knew that we were capable of doing that. But along the way, certain things come up. So as you're delivering the service, you start to see that the way that people interact with care is different to how you might have imagined. And what was interesting for that particular contract for us is that the way that the psychological therapy service was commissioned was you got paid a certain amount of money for, it's a tariff based for each session that a patient attended. And one of the disadvantages for us was we actually got paid a lot less than we were expecting because patients were recovering a lot quicker. So, and that's, it was for me because it was one of our earlier contracts. I kind of couldn't believe it because having worked in the commercial sector for years previous, I didn't see how somebody who can get someone better quicker would be penalised for that financially, and you would almost be incentivized to drag out the care because you could get paid more for it. So that was really interesting learning for us. Obviously, we delivered the treatment in the period that it took to get people better, and we happened to get paid less as a result. But I think that being able to feed back to commissioners about the way that certain things are commissioned, so as they don't kind of create those false negative incentives, is really useful. And that's why I'm pleased that there's all this kind of value-based procurement being thought about today that I think is really going to drive improvements in the system, because we're not thinking about just paying for activity. We're actually thinking about delivering payments based on, outcomes which matter to people's real lives.
In the kind of securing of that contract, from your team, who was actually involved down on the ground, like doing the legal, like governance, CQC, whatever, like who in your team was doing that work?
So it depends on the contract. So we're talking about a specific one here, but you have so many different types of contracts. So it depends what we're contracted to deliver. So Sleepstation is lots of people would think of it as an app because it's a digital service, but I always try to make sure that we're clear to people that it is a service. So there's lots of different elements of what we do. So some of that is really early stage onboarding, so making sure that we mitigate digital exclusion by actually having an option for somebody to phone someone, explain to them how things work, help them get up with an account to start with to make sure that they understand how the process works, and it's obviously designed to be really simple once they're in, but lots of people have that initial fear about getting into something that's kind of framed as digital where they might not think that they're tech savvy or whatever. So that bit's important, and sometimes we're just commissioned to do that. So as our services evolved over the years, there's different things that we do. So some of it's around onboarding people into different systems, some of it's delivering our own therapy programs. So depending on what we're contracted to deliver, the teams that are involved are different, but clearly there's governance, there's technical security, there's legal for contract, and I think it's very difficult for smaller organisations who've maybe got one person who wears many hats to be able to have those conversations at the level that they need to be had. And I think that's where some people kind of end up tripping up, because it is difficult to understand all those different elements in such a big system as the NHS.
So you mentioned, I suppose, in your first contract, you were surprised by how quickly people got better. So you kind of experienced a loss. What other lessons did you learn in the early days when, I think in my experience, you think, oh, I've got like a national contract and everybody's going to use it and that's going to be amazing. But you may get it commissioned, but then you have to persuade people to use it that may not have chosen it themselves. So can you relate to any of that, or are there any other examples that you could give?
With the NHS contract, so if we talk about that, so in 2016 our service was commissioned by NHS, so it was available nationally, but under that contract, we were restricted in terms of what we could say about it. So we weren't actually allowed to say that it was available nationally. So we were available if GPs knew about us, or if patients came to us and said, oh, can I access this service? Obviously, we would say to them, yes, you can. But we were prevented from marketing it. And that was because of a perception that if we did market it, because we didn't have any restriction through the geography, because it was a digital service, that request for the service might be really high and it might end up costing the NHS a lot of money. So they were kind of trying to restrict it by saying, don't market it. What that did for us, actually, so at the beginning it was really frustrating, because we were thinking, well, hang on a minute, we've technically this service is available everywhere, and we can't say anything, we can't do any PR. Actually, there's some people who've got such a small remit compared to what we've got in terms of commissioning, that are making these statements that they've got the biggest service, and you're like, oh, I wish we could say that that isn't the case. But you just kind of have to sit there and accept these are the contract and terms that we've signed up to. But the beauty of it that came out the other end is that what actually happened is it grew massively and amazingly through word of mouth, because when GPs used it and they referred their patients and their patients got good outcomes, they then kept using it and referred more and more patients. And then as they moved around, particularly locums became a really good referral source for. They were moving between different practices and saying, oh, by the way, do you know you can refer to this? So we ended up getting this huge network of primary care advocates. And that's what's really helped us to evolve the service, because what we've done over the years then is looked at, so NHS England informed us in 2020 that the way that this service was commissioned was no longer in the remit anymore, and that it was going to be shifted. I think it was in 2020, but it was just at the time whenever CCGs were becoming ICBs.
Yeah.
We were being told, you've got this national contract and you're seeing thousands of patients every month, but it's not going to be funded nationally anymore. You're going to have to go and negotiate all these local contracts. But these organisations that you're going to be negotiating with, by the way, they're all going to be disappearing very soon. And they're going to be merging into these other organisations that don't actually exist yet. But, crack on with that. So that was difficult. And we thought, oh, are we going to be able to secure these contracts in all these areas that don't exist, and how, what do people think about us? And what was great about that is when we went to the GPs and all the kind of teams on the ground who'd been using us for years and said to them, by the way, this decision's been made, we were so surprised by how much support we had, saying, oh, we don't want to lose this service. We'll make sure that this can be retained. We'll, whoever the team are that pick this up going forward, we're going to advocate for the service, and we're going to make sure that it's put back in place. So we ended up being able to secure contracts in 39 of those regions. And at the time, I think I was still a bit naive to how things work. And when people talk about delivering services at scale, I always just assumed they were doing it at a similar kind of scale to us. But then I started chatting to our now medical director, Joe McDonald, who had set up the Great North Care Record and kind of understood a lot more about what was really happening. He's like, do you know what? This isn't happening. People don't do this. They don't move from one contract to contracts across 39 regions almost seamlessly. Like, there's something here that's actually that you're doing right, that we should be thinking about understanding a bit more and replicating. So then we got some funding to work with different areas to look at what made those areas different, the ones that had used Sleepstation when we had that national availability, who had found out about it and decided to use it. We wanted to know, were they using it because they didn't have anything else, so that's why they came to us? Were they using it because they had a bigger need, because there was more demand for sleep care in their area for whatever reason? Were they using it because their patients were more digitally savvy and they would be more interested in a digital product? So what we ended up doing then, in addition to having some of these contracts shift into other forms and the service still be available in those areas, but just in different ways, is to run these projects to say, well, where hasn't it been used and why, and how do they differ? And that's been really interesting, and it's helped us to understand what the real problems are on the ground as well, and working more closely with PCNs to say, well, what can we do for you that would refine how our service and make it better for you? Because obviously we were restricted by some of the other contracting, the ways we could accept referrals and stuff. And that's been really interesting. We've definitely managed to enhance what we offer and be a real support to those teams, just by, it's probably it seemed like an awful thing to say, oh, this contract's going away, but I think it was a blessing in disguise, to be honest.
Would you be able to just share, who are your actual clients? So you've mentioned primary care networks. Who else commissions your services now?
Oh, so it's a range from ICB, Place, primary care networks, GP federations, even some large GP practices in their own right. So it's really varied. We don't have one single kind of route to market, and because we do different things for different people. So in some areas we'll be looking at deprescribing initiatives, in other areas we're looking at reducing waiting lists for mental health services. I think because we've been around for a long time and we've been able to we've developed all these proof points. We can say, oh, when we work with these teams and did these things, For example, when in the West Midlands, we've got evidence that when the service wasn't available for a bit, referrals to hospital went up by 30%. So in that area, it makes a lot of sense to say this service supports the local hospital. So depending on what we're wanting to do regionally, the contracts are different and they're with different people. But yeah, it's very varied. It's certainly not a single solution anywhere.
And in regards to the data you collect, how often are you collecting that data to kind of measure like your performance?
Oh, daily. So we're kind of obsessed with data. Yeah. So we've got lots of internal dashboards where we've established baselines over the years, and for initial engagement, for therapeutic outcomes, for onboarding. So like kind of at every stage, we've got different thresholds that we would say we don't ever want to drop below this internally. And then we've got other metrics that we're working with teams locally around, so getting people back to work, other comorbidities, so people with chronic pain and sleep problems, can we reduce their pain? We did some work with the NIHR looking at post-surgery patients. Is there some stuff you can do there, kind of pre-op? So depending on what we're looking at, there's lots of different metrics. And then what we're trying to do is also look at what the kind of value add is of that. So where's the benefit to the system, not just in our data.
When you're having conversations and not necessarily looking for opportunities, but you're just, you're naturally having conversations, I think chronic pain you've just brought up is really interesting. But there'll be lots of organisations. So I think chronic pain, it's mentioned in the 10-year plan. It feels like lots of people are talking about chronic pain, and rightly so. It's a huge issue. But there's lots of competition. They're not your direct competition, but they will be saying, we've got services to support chronic pain. You'll be saying, our services can support chronic pain. So whilst you might not look at your competition, sometimes your competition is hidden. Do you acknowledge that? Can you see that or not?
It's really important and healthy to have lots of different people thinking about problems in different ways. We might not come up with the best solution, and if we don't have the best solution, we shouldn't be the ones delivering the service. I think so long as things are fair and transparent, and we're clear on what the goals are from the outset. So if there's something that's coming up for a tender, for example, I think it should be really clear what they're looking for those who might win that to deliver. But if you're looking at the way that we tend to work is more saying, in this group of patients that we've got, we're seeing really high percentages of them that have these specific problems. Is there anything else we can do for them as part of our service? So we're not really saying, oh, commission this as a chronic pain service, but we're saying, are there any resources we can give them? Can we direct them to things locally? So one of the big things that came out of our work that we did during COVID was to say, where could we signpost people to local services without them having to get bounced back to the GP? Because obviously some of those services just, they weren't able to go in and sit and chat to somebody, but we've got direct access to patients through telephone and our online chat system. So we gathered lots of data for the whole country around where different services existed, particularly things that patients could self-refer into, and where there were resources. So we could say, well, if you've got this problem, these things are applicable to you. So that's something that our coaches do today. They'll really help people to get engaged with those things that they can already access, but maybe they just don't know about. So it's not necessarily about promoting our services. It's about kind of working together holistically for the system.
I'm not saying competition is bad, but I suppose on the other, as somebody that could commission services on behalf of a primary care network, I would never have thought, but maybe because I'm not clinical, that Sleepstation could potentially support that. But I've got a limited budget and I've gone in a different direction. So it's not to say that competition is bad. It's just there isn't enough money. And sometimes, like you don't know what you don't know. So I could commission a service which supports the thing that I can see, like in front of me.
Yeah.
But I've not thought, okay, well, what are the wider factors that potentially it could tick another, like a different sort of service could tick more boxes. So it's not bad. It's just the point of these conversations. It's just really helpful. And I think the competition might be invisible, but it's hard for the customer to know where are they going to put their pounds. There's not an abundance of money to go, right, I have this, I have that, I have this, I have that, and they may all overlap, and that's great. It doesn't really work like that. You have a few people looking at a specific problem, and that will drive the solution that they want to purchase.
Yeah, and I think that's really important to work with the local teams to understand the problems that they're trying to solve. I think that's probably where a lot of people misstep in trying to get their things commissioned, is they think about it from their own perspective. They think, I've got this thing, these are my primary outcomes for my thing, and I see this as a big problem, and you should be wanting to pay for this, and this is how much it costs. But they aren't very aware of the budget that primary care networks actually have. Like that's the important starting point, and to think about what percentage of that budget are you asking for.
Yeah.
If you just did that work yourself, you would save a lot of time talking to people in primary care teams that your solution isn't a solution to their problem, because they just don't have funds, even if it was the best idea in the world. So you have to be realistic about it, and also I think you need to be aware of what else is available, and how you can fill in the gaps, like where certain things, where there may be obvious gaps, and do it cost effectively and in a way that is kind of de-risked for the commissioner as well. You don't want to be going in and saying, well, take a risk on this for this period, and we'll write up the outcomes, and maybe in a year and a half's time you might see if it was effective. And that's at the point where you'd already had to make the decision about whether you want to recommission it. I think that's why a lot of people get stuck in that pilot kind of, there was a term someone used the other day for it, was really good, but they just repeatedly do pilots that don't go anywhere, and that's wasteful for everyone, because it's not helping the businesses, it's definitely not helping the system, and patients get really confused, is this thing available or is it not, or it's there or it's gone again. So yeah, I think that's one of the things we need to try and avoid going forward.
I think this is universal, but my world is primary care.
Yeah.
Is to understand the budgets and to think very carefully about the percentage of the budget you are asking for. I just think that is gold and so underestimated. And I think that people don't understand, and it will probably be the same in secondary care. Everything is a priority. So everybody, like you're competing against, type 1 diabetes, cancer, you've got sleep, you've got chronic pain, like everything is important. Everything is important. But I think I have so many conversations. I hope people stop and rewind this and make notes, is to really try to understand what you think you are asking for. Yeah. Because a lot of that additional role reimbursement scheme money at the moment, everybody's got their eye, everybody thinks their service can be funded by that pot of money.
People think if the delivery method is scalable, then it's scalable. So if I've proven it in 10 GP practices, that means I can do it in all the GP practices and I'll get the same results. Well, you won't. So that's something that we need to be really clear about. So every area of the country is different. Every primary care network is different. And the patient groups are different, and how they'll interact with things and what else they've got available to them is different. So it's not going to be the same as a pilot study that you did where you got some results, or certainly not as a randomized controlled trial, because the real world is so different. So I think we really need to focus on having real world outcomes to begin with, and then you need to have real world expectations of other people's time. So I think that's one of the things that people miss when they're trying to get their thing purchased, is they forget that these people that they're wanting to meet with to kind of sell their product or whatever, they've got so many other priorities, like you say, tiny budget, no time to discuss this, can't get into the detail of what you've got to offer unless you're really solving their problems. And I think the only way you understand their problems is to go in there to understand their problems first, not to try and sell something, genuinely to try and figure out. And that does start with looking at what the budget is, because I think if someone coming to bringing a product to market in the NHS looked at the budget, they probably wouldn't go near primary care. They would be like, no.
When people come to me, I think, do you really want primary care to be your business? Like, really?
We don't need to work with primary care, but we do work with primary care because we know that they are like the front line. Yeah. Everyone goes there. So many of them need so many things, and there's no money to provide it. So if you can find a way of delivering something really cost effectively, and often that means pretty cheaply, but that's effective, then that can be a great thing to deliver, so long as you're not asking for £5 per patient, because that's never going to work.
So I asked you, when you got in the early days when you got your services commissioned, did you experience any growing pains in your digital service? And you said, well, no, but because you knew enough, you knew that you could scale with potentially without growing pains, But now you've just highlighted people do experience those growing pains with a digital service because they think we scaled it 10 times, we can now scale it 50 times. And they may not have the evidence to do that. They may have some experience in a set of principles and fundamentals, but sometimes that scale, 10 times, 5 times, it does show cracks. And that's business, that's okay. But I think that was the point I was getting at. People think that they can do it because they've done it on a small scale. Doesn't mean they shouldn't go for the bigger contracts, because you have to start somewhere. But I think it is important to understand your capabilities, and knowing when to, I suppose, and doing that risk assessment, and maybe having partners.
Yeah, and the things that come out at scale, so groups start to emerge. So when you're seeing, you support a small number of patients, you might get the odd one with this thing easily managed. When you have a whole group of people with this thing, that's very different, and it becomes your responsibility to make sure that those people get the right type of support that they need as well. So there are things that come with scale that just don't exist in smaller scale delivery methods. But there's also the system. I think people don't. The bit that always gets me is when there's these comments that like, oh, because this thing is automated, for example, Sleepstation is not an automated service, so it doesn't apply to us. But if something's automated, the assumption is, therefore, we could just roll it out across the whole country, and wouldn't that be great because it's cheap? But you really need to think about what then. So what if that thing that you've now given to everybody doesn't work? What burden are you placing on the system that you didn't consider it before? And one of the keys for me in insomnia was when the daridorexant drug got approved. So really expensive drug, now available for chronic insomnia if CBTI has been tried and doesn't work. So now there's a risk to the system, right, and rolling out ineffective CBTI. Because if you do that and people get access to this thing that they don't engage with or that hasn't worked for them, then you get this big group of people who suddenly, not just from a financial point of view, now are eligible for those drugs because technically they've ticked the box of having tried CBTI and it didn't work. Well, we need to understand why it didn't work. Did it not work because they didn't engage with that particular option? Did it not work because the timing wasn't right? Timing's really important in CBT. What's the reason it didn't work? If the providers aren't reporting back on why it didn't work, if they're not reporting back on how many sessions they completed, what their feedback was, if they're just looking at access, how many people signed up because that's what we're charging for, that doesn't work for the system. So there's things that I think you have to have that system level thinking if you're going to really deliver impact at scale. And what scares me is there's lots of noise post 10-year plan around people having digital things that can deliver access at scale, but access isn't the solution. You have to have impact. You need engagement. That has to be like the key thing. If people don't engage with what you're offering, they're going to try that and then need something else, and that's not a good place for primary care because then they just end up back at your door going, oh hi, what next? And and then maybe feel like that they're a lost case and that they're dependent on medication for the rest of their life, and that's the worst outcome for everyone, isn't it? So yeah, I think that bit, being really mindful of the bigger picture, is so important in commissioning.
Alison, if people want to get in touch with you, where should we send them?
They can go to our website, sleepstation.org.uk, or LinkedIn. I'm on LinkedIn if they want to talk to me directly. Alison Gardiner.
Thank you so much.
Oh, thank you. It was lovely to chat.
So hopefully you've just watched / listened to Alison Gardiner, who is the CEO of Sleepstation. And the key takeaways I took from this episode is that sometimes there is a myth that something digital automatically means it's scalable, and it doesn't, because the environment is really, really important. Another key takeaway, and it's so important, and that is to understand the budgets you are potentially going after and what percentage of the budget your service or tool or whatever costs. That is really, really important, and something that I see happen all the time in primary care. A lack of understanding, a lack of appreciation of the actual budgets that are available and what other eyes are on that budget as well. Then the final point I took from Alison is, whilst lots of people will be trying to work with the NHS to think about how their solution improves or increases access, also think about the impact of that access. I hope you found this helpful.